A very good evening, everyone, to the valued audience of the Mega Online course from Manchester. I'm Mahmoud Al-Kulani. I'm a Senior Registrar of Pain Medicine and Anesthesia, consultant to be very soon. And I'm really honored to be with this esteemed group of elite, prestigious professors. I'd like to thank Prof Mahdi for giving me this chance to be with you here today. And I'd like to express my gratitude to him for his endless effort with the Mega Online course. I'm here tonight to welcome actually a real star in the field of critical care and anesthesia, Prof Elansary, Professor of Anesthesia, Critical Care and Pain Medicine at Ancient University. I think words cannot express the value and the caliber of Prof Elansary, and you've been throughout the Mega Online course enjoying his lectures and learning from his endless knowledge. So tonight we're gonna enjoy a prestigious lecture from him, and at the end of the lecture we'll have the chance to receive questions. If you have any at all, feel free to put them in the question and answer section of the Zoom program, please. Thank you. Off to you, Prof. Elansary.
Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Mahmoud. And before I start, I want to thank you for your nice introduction. And really, I am happy today too much to see you after these years. You one of the best and genius colleague which I have met before in my experience. Good evening, my colleague. Today I am going to speak about some cases which prolong the obstetric emergency, because I know today is a day of obstetric emergency. And so I will try to highlight some of the critical cases or critical topics which mostly we can see in our ICU. The first case, a 32 years old lady admitted to the maternity ward at 34-week gestation, gravida 2 para 1 with upper abdominal discomfort and sensation of her shoes and rings are too tight. This meaning she is edematous at start, and at 34 weeks, I think this is a critical time. She has not attended any antenatal care, and so there is some neglection in her care. On examination, she has fundalite of 35 centimeter and 8 beads of colonoscopy. So we suspect this is some sort of pre-ectoxemia of pregnancy, and I think mostly will be eclampsia. Her urine appears dark. Her observation are as follow: heart rate 102 beats per minute, sinus. Blood pressure is 150 over 87, so she is hypertensive. Respiratory rate 20 beats per minute. Saturation 100% on nasal bronch 4 liters per minute. Temperature 37.1. What is the management conflict of do you face for these patients? I will try to run quickly on the cases, and I will explain and discuss with you through our reading the cases. The lab investigation, as we see, urea 5.9, creatinine. The abnormality here we can see albumin is low, bilirubin I think is high. Liver enzymes, STLT are high, and GGT also, maybe stasis, and alkaline phosphatase also. pH 7.43, which is normal. The normal pregnant patient is some on the side of alkalemia slightly. Hemoglobin is low, 94, so there is decrease in hemoglobin. Platelets 1,025. This is low thrombocytopenic. PTT is prolonged, which indicates some problems in intrinsic coagulation. BT also prolonged and INR, this means a problem in the extrinsic coagulation. Urine protein is also 3+, and so there is proteinuria, and so there is some edema and hypertensive and some decrease in the hemoglobin and thrombocytopenic, and I think these are classic presentations of the syndrome, which we know as HELP syndrome, which is characterized by hemolysis, elevated liver enzymes, and thrombocytopenia. And HELP syndrome is one of the toxemia is the end extreme of toxemia of pregnancy. Most of the patients are present in about 20% of cases exhibiting preeclampsia. These patients demonstrating features involving preeclampsia and Herpes syndrome. However, 34 weeks gestations, fetal lung maturity is underdeveloped, and so we have to give steroids 24 hours before, of course, before delivery. And the classic treatment here, or the best, is delivery if the time is optimum, and I think 34 we can deliver sufficient. Providing this period with excessive risk to the mother health and is a delicate timing issue. Operative intervention here in the setting of an uncontrolled coagulopathy, of course, presents some increased bleeding risk. And so if the patient needs some supportive therapy like replacement therapy, as some of the coagulation factors and cryoprecipitate, fresh frozen, and so on, and platelets if the patient is bleeder or suffering from bleeds or the platelets is too low. Also, conflict here, the blood products used to correct the coagulopathy, we sometimes are afraid from using it because it may induce in some patients pulmonary edema and it has its risk. And so we are judging or balancing the situation, so not affecting the renal perfusion and at the same time try to correct the replacement, the coagulation defect. Preeclampsia and Herpes syndrome, and it is always in the third trimester, this patient suffering from third trimester hypertension, she complaining from tachycardia and tachypnea, and I think this is a physiological. More than 3 or 4 beats of colonus indicates some sort of hypertonicity, or some meaning the patient developed eclampsia, and so these patients need urgent delivery to cure the situations. And with her elevated blood pressure, peripheral edema from the tight ring and shows and proteinuria, this meaning this patient suffering from Herpes syndrome. Elevated liver enzyme, hemolysis, and low platelets, thrombocytopenia. The largely hepatic liver function test suggests that there is more just than preeclampsia present and information, because elevated liver enzyme or affection of the liver in cases of preeclampsia is not so much, not occurring so, it is rare in preeclampsia, really. But if we find the liver enzyme is high in such situations, we can reach the conclusion of Herpes syndrome. Therefore, the upper abdominal discomfort may represent hepatic congestion, or maybe subcapsular hematoma, or hepatic infarction in some cases. The raised bilirubin may be due to one of both, maybe hepatitis, maybe hemolysis. We have to exclude the other causes. And always, when we are in front of such cases, which is the imitators of preeclampsia, we have to differentiate, because we have many syndromes which may be like each other in its presentation, clinical presentation, and lab result, especially Herpes syndrome, DIC, fatty liver infiltration, even TTP and hemolytic uremic syndrome and liver failure may mimic such situations, and so we have to differentiate to reach the correct management of such patient. Another case, 21 years old prime gravida at 35 weeks of gestation, was admitted with labor pain, headache, epigastric pain, blurring of vision, which is the combination of symptoms always we face in such situations. On examination, there was altered consciousness, pulse rate 86 per minute, blood pressure 170/110, hypertensive. This patient breathes 24 per minute, alkalotic, of course, and the breast tendon jerk. And so there is some sort of hypertonicity in such a patient. Based on obstetric examination, delivery by vaginal route was planned at start of admission. Baseline investigations show hemoglobin 11.9, platelets 160,000, blood urea 26, serum creatinine 0.9, normal. Within normal, the investigation, even the liver enzyme are within normal. And the patient, we start to treat hypertension with oral nifedipine and magnesium sulfate for the conversions. After 4 hours of admission, repeat exam shows the patient also the pulse rate 84, blood pressure 160/100. Urine output was decreased to 50 ml per hour, and so we stopped magnesium sulfate and only resume nifedipine. After 2 hours, patients had an episode of generalized tonic-clonic seizures, and so diazepam started to be given intravenous to control the convulsions. And at that time, we decided to proceed for cesarean section. Following extubation, the patient was drowsy, disoriented. Over the next 12 hours, she had 4 generalized seizures activity, despite continuing intramuscular magnesium sulfate. Blood pressure ranged from 160 to 200 millimeters systolic and diastolic 110 to 130 millimeter mercury, with heart rate between 120 to 130 per minute. At this time, oliguria and tender hepatomegaly was noticed in this patient. And because of persistent seizure activity and hypertension, magnesium sulfate and labetalol continue IV infusion and guided by the knee-jerk response for following up magnesium sulfate to avoid high dose or toxic dose. Repeat lab investigations after 24 hours revealed drop in hemoglobin to 6.8, platelet thrombocytopenic 86, prothrombin time increased by 7 seconds over the control. Also, PTT was 8 seconds more than the control value, and the liver enzyme ALT, AST, and LDH, which indicate hemolysis, are also evident. And so this scenario, this case, I think all of you agree me, it is also HELP syndrome, elevated liver enzyme, thrombocytopenic, and hemolysis. And we see in such patients, the HELP syndrome developed after delivery, not necessary to develop in the 3rd trimester, may develop after delivery, may patient normal till the delivery and started to suffering from HELP syndrome. Of course, in such situations, we have to differentiate to reach the differential diagnosis, to reach the optimum diagnosis. We have to exclude the anti-phospholipid antibodies, and it is done, and it was negative. Both infusions were continued for 36 hours after the last seizures, and a total of 260 milligrams of labetalol was used. Blood and fresh frozen plasma was transfused, supportive treatment, ordinary supportive treatment, and the patient started to improve after 10 days and discharged after 12 days. They help 2 cases exhibiting HELP syndrome. And so HELP syndrome is a multi-system disease, resulting in generalized vasospasm, microthrombi formation, and coagulation defect, and leads to microvascular endothelial damage, intravascular platelet aggregation also. And so we have to differentiate it from other causes of microangiopathy, such as TTP and HUS, hemolytic uremic syndrome. And we have to be aware of the significant symptoms also of and the signs of preeclampsia, which is mostly headache, blurred vision, altered consciousness, clonus, increased serum creatinine level, consumption coagulopathy, thrombocytopenia, and abnormal liver function test. But if the liver function test is too high or clearly to be elevated, we can go to the diagnosis of HELP syndrome. 70% of cases occur between week 22 and 36, with 20% occurring within 48 hours of delivery. This is a HELP syndrome. Features of preeclampsia occur in the majority of patients presenting with HELP syndrome, but sometimes some patients are not suffering from preeclampsia, and they can develop HELP syndrome without symptoms of preeclampsia. 10% to 20% of patients with severe preeclampsia will develop HELP syndrome, hemolysis, elevated liver enzyme, and low platelets count. Platelet count, of course, is the best indicator of herpes syndrome, and in fact, there may be no evidence of preeclampsia before or during labor in 20% of cases. Herpes syndrome alone, independent of preeclampsia. The lab abnormality typically worsens after delivery and peaks 24 hours to 48 hours postpartum and resolve by 3 to 4 days. Positive D dimer, some say positive D dimer test may prove it is a herpes syndrome. No, till now, D dimer, as you know, appear in many situations and has many other underlying causes, and so it is not a conclusive parameter to diagnose herpes syndrome. Patients with herpes syndrome should be treated prophylactically with magnesium sulfate, of course, and antihypertensive agents, and to reduce also the maternal morbidity such as cerebral hemorrhage. A mainstay of treatment in such situations is the delivery if the time is optimum, and if the patient is suffering or the baby is suffering or there is intrauterine fetal distress, we have to deliver the patient. These patients may develop placental abruption and require emergency cesarean section. Altered consciousness and the platelet count of less than 70,000 per cubic millimeter, of course, prohibit or try to avoid using spinal or regional lumbar spinal or liver disease is unique to pregnancy and common in pregnancy, as we see in first trimester, second, third trimester, and postpartum. Herpes syndrome occurs in the second, third, and in the postpartum period. Acute fatty liver mostly in the third trimester, and severe preeclampsia in the second and third trimesters. Hyperemesis gravidarum, also one of the causes of admission to ICU, occurs mostly in the first trimester, and the intrahepatic cholestasis of pregnancy occur in the all trimesters of pregnancy or all over the pregnancy. Pathogenesis for the herpes syndrome, vascular remodeling and the uteroplacental ischemia and the defect in the formation of the placenta and the immune-mediated mechanism has been proposed, especially in patients who exhibiting or who are suffering from some gene variations like glycocorticoid receptor gene abnormality, toll-like receptor 4 gene, vascular endothelial growth factor gene, cluster differentiations 95, coagulation factor 5 leading mutations. All these patients are liable for herpes syndrome or liable for microangiopathic malformations of the placenta. Of course, the clinical presentations, you will find your patients gaining weight and suffering from right upper quadrant pain, nausea, vomiting, especially nausea and vomiting more evident in fatty infiltration of the liver more than in herpes syndrome, or non-specific viral-like illness. Jaundice is seen in 40% of patients, and the concomitant signs and symptoms of preeclampsia may or may not be present with herpes syndrome. Severe right upper quadrant abdominal pain may have impending hepatic rupture or hepatic infarction. We have to be cautious, and some patients may need urgency. Thrombotic microangiopathy leads to microangiopathic hemolytic anemia and liver damage in patients with herpes syndrome. Other right upper quadrant pain in pregnancy, of course, we can differentiate from acute cholecystitis, acute pancreatitis, peptic ulcer disease, acute fatty liver disease, pregnancy, reflux, and so on, many causes of right upper abdominal pain. Pregnant women with preeclampsia or herpes syndrome may present with involvement of other organs, may coming with cerebral or visual symptoms, may coming with pulmonary edema, renal insufficiency, because as you know, it is a microangiopathic process, and so may affect other organs and leads to even to renal insufficiency in some situations. Liver enzyme abnormality are seen in up to 10% of pregnant women with severe preeclampsia. Not all patients with preeclampsia exhibiting liver disease. Of course, there is classifications, many classifications for the herpes syndrome according to the level of liver enzyme and the LDH and thrombocytopenia. And the class 1, of course, carry a worse prognosis and longer hospital stay. And the trend, we can follow those patients with platelet count and serum LDH are predictive of speed of recovery. Other causes which simulate HELLP syndrome or imitate HELLP syndrome are acute viral hepatitis from hemolytic uremic syndrome, in which there is some problem in the complement 5, thrombotic thrombocytopenia, which, as you know, manifested by neurological manifestations, renal manifestations, and thrombocytopenia and hemolysis. Antiphospholipid syndrome and fatty liver infiltration. All these syndromes may really imitate the preeclampsia and imitate the severe preeclampsia, which is the HELLP syndrome. The classic hepatic lesion associated with HELLP syndrome is periportal or focal parenchymal necrosis. And of course, it may be difficult to take biopsy, liver biopsy, to confirm your diagnosis during such situations in which the patient suffering from coagulopathy, and so biopsy may be dangerous in such situation. Management here, of course, bed rest, control of hypertension, IV magnesium sulfate, prompt delivery is very essential before the patients develop DIC and liver infarction and hemorrhage and so on. Corticosteroid may improve the lab abnormalities, but not affect the progression of the liver disease. In some situations or in some cases of severe HELLP syndrome, we can use plasma exchange, especially after delivery. We can use 5-6 sessions until the patient's lab investigation improved. Hepatic rupture is common in such situations, and even hepatic infarctions, and the surgical intervention and the radiological intervention is very important here, and up to liver transplantation in some cases. HELLP syndrome can recur in subsequent pregnancy, and you suspect in such patients the patient may suffering after that from some vascular problems as hypertension or even psychological manifestation like depression and so on. And so those patients are liable to complications in subsequent pregnancy. Acute, we have to differentiate HELLP syndrome also from the acute fatty liver infiltration. Acute fatty liver infiltrations mainly due to problems in the mitochondria due to deficit some enzymes in the mitochondrial trifunctional protein deficiency. And so those patients are liable to shed the deficiency protein, and so liable to toxic metabolites accumulation in the liver, producing HELLP and acute fatty liver and the preeclampsia, and the stress and the feeding states are affecting, and even the environmental stress and the high fat diet all contributing to acute fatty liver infiltration, and so we have to avoid. The symptoms in such patient in acute fatty liver specifically they come with headache, fatigue, nausea, and vomiting, right abdominal, right quadrant gastric pain, and jaundice also in 70% of cases, more than in HELLP. Also, I think hypoglycemia is very common in acute fatty liver infiltration, and so you can distinguish differentiate between HELLP and fatty infiltration through these hypoglycemic parameters, which is common in acute fatty liver. Hepatic encephalopathy may be seen in neglected cases of acute fatty liver infiltration also. Hypertension, edema, and ascites. Half of the patient may have associated preeclampsia and upper gastrointestinal hemorrhage from coagulopathy, associated coagulopathy. Those patients are suffering from hyperammonemia also, renal failure, in severe cases, severe coagulopathy, hemorrhage, leading to death of the mother and fetus if neglected and not terminated quickly. Peripheral blood smears may demonstrate thrombocytopenia, may demonstrate disseminated intravascular coagulopathy is common in such situations. Prothrombin time, partial BTT also increased. Fibrinogen may be abnormal. Urine analysis is very important for revealing ketones, protein, and bilirubin. Blood urine nitrogen creatinine also may be elevated, and uric acid in such situations. Microvesicular hepatic steatosis is characteristic to acute fatty liver activation, and the mitochondrial dense body are present. And as we said, the problem in the deficit enzyme in the mitochondria. Management here also is a delivery. And prothrombin time improvement is the first sign of hepatic recovery in such situations. Liver transplantation is an option if the patient didn't improve after delivery due to liver failure in some patients. Preeclampsia is associated with both disorders, HELP and acute fatigue. It is common, of course, in preeclampsia. And so we can see differentiation among imitators of preeclampsia, which are very important, and we have to consider in any pregnant patient: preeclampsia, HELP syndrome, TTB, HUS, acute fatty liver, antiphospholipid, lupus flare. All these imitates the toxemia of pregnancy, and we have to differentiate. Frank hemolysis need for dialysis and the neurological involvement and so on. These are characteristic to thrombotic microangiopathy, TTB, and as you know, TTB due to defect in the Adams 13 activity and leading to blood activation and high coagulability. And the treatment here is the best is the plasma exchange. No replacement transfusion here, only plasma exchange for such patients. Several disorders imitate preeclampsia again as gestational hypertension, chronic kidney disease, acute fatty liver or pregnancy, thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, acute exacerbation of systemic lupus erythematosus, which need anticoagulant and immune suppressant, and severe hypothyroidism and sepsis. All these imitators must be differentiated from preeclampsia. The pathophysiological causes of all these conditions, I think, the same pathology: vasospasm, platelet aggregation and activation, destruction, microvascular thrombosis, endothelial cell dysfunction, and reduced tissue perfusion and placental ischemia as well. Preeclampsia-like syndrome induced by severe COVID-19, I want to mention because there are some cases reported in such situations in patients suffering from severe COVID-19 and coming with pneumonia and on ventilator support. They may mimic exactly the preeclampsia and HELP syndrome. And so we have to concentrate on important point: don't be hurried in such situations and deliver your patient. The patient will improve just after the pneumonia subsides. And in such situations, really, there is maybe increasing increasing the angiogenic factors. And if we can make the angiogenic factors, it can differentiate the patient who have really HELP syndrome or preeclampsia or toxemia in general or pregnancy, and just a coincidental similar condition due to polypharmacy and respiratory and cardiovascular affections. And so if we can make the angiogenic factor and we detect the angiogenic factor, which is deficient even by 5 weeks before the symptoms of HELP syndrome, it is absent in COVID patients who are suffering from such situations. And so placental growth factor and the soluble like tyrosine kinase and the placenta-related angiogenic factors and uterine artery pulsatility index may help us in differentiating between patient really suffering from HELP syndrome and the patient just giving or mimic the picture of the of HELP syndrome due to COVID-19 infection. Those patients really improving after improvement of pulmonary functions and weaning from the ventilators. And so we have a more conservative management with adopted in COVID-19 patient during pregnancy. Don't hurry in delivering your patient. The patient may improve after healing or after improving the symptoms of the COVID-19, especially pneumonia. As we know, in thrombotic microangiopathy, there is deficiency in Adams 13 and a von Willebrand factor cleaving, which is cleave von Willebrand factor, and so the thrombotic microangiopathy is high, of course, and so these patients need plasmapheresis, as I said. On the other hand, the patient with atypical HUS, which is due to some problem in the complementary regulatory proteins that cause high activation of the alternative complement pathway, especially complement number 5, and such patient need eclasimab may be effective in such patient. Interestingly, pregnancy itself can be a trigger for Adams 13 deficiency in TTP and HUS. So the abnormality in liver disease may be abnormal in TTP and HUS. They are usually not so prominent like HELLP syndrome and overshadowed by the microangiopathic anemia and thrombocytopenia, which would help to differentiate them from HELLP syndrome. Perhaps the most obvious diagnosis to exclude also lupus flare is liver pathology is generally not present in lupus. Also in antiphospholipid syndrome with or without lupus may present with liver dysfunction. Despite this, the dominant feature are thrombosis, of course, in antiphospholipid syndrome, and these patients need of course, anticoagulant to avoid thrombotic formations and defect in the perfusion, either venous or arterial thrombosis. It is important to have an accurate diagnosis for proper treatment and long-term implications of therapy. And for example, if we diagnose your patients as HELLP or acute fatty liver, you have to deliver the patient. If the patient is suffering from Adams 13 deficiency and high activity of von Willebrand, you have to make plasmapheresis. While the new agent eculizumab is a target inhibitor of complement C5, and it is effective in treating HUS. Also, on lupus flare, we have to give immune suppressor for those patients and anticoagulation for treatment of antiphospholipid syndrome. And so the differentiation is very important for differential diagnosis, very important for selecting the optimum treatment for your patient, which maybe gives the same pictures of toxemia or HELLP or acute fatty liver in pregnancy. Especially, as I said, antiphospholipid syndrome, HUS, acute hemolytic or atypical hemolytic uremic syndrome, and other diseases. Learning point or important point here, significant cardiovascular outcome after an episode of HELLP syndrome may ensue for decades afterward. Your patients may suffering after that from hypertension, from diabetes, from vascular disease, and so on. And as I said, may develop some psychological problems or an anxiety and depressions after several years. Another case, 33 years old woman, gravida 3, para 1, was referred to our hospital due to abnormal placental diagnosis during routine sonographic examination at 27-week gestation. She had a history of prior cesarean section due to placenta previa. 5 years earlier, on admission, the patient presented spotting of blood with or without abdominal pain. An urgent abdominal ultrasound examination showed viable fetus with biometrical parameters and normal amniotic fluid, while transvaginal echo Doppler image suggests the diagnosis of placenta previa. I wanted to throw this case to stress on important points. Take a patient who developed placenta previa or abnormal position of placenta, placenta accreta, placenta increta, and suspected postpartum hemorrhage. You have to arm yourself before going to theater. For such a patient, you have to inform the intervention radiologist, and you have to prepare or arm yourself by patient may need uterine tamponade, may need uterine artery embolization, or just localization of the vessels feeding the tumor, vessels feeding the placenta, which is separated, and so on, to avoid the postpartum hemorrhage, which is very common and highly severe. And even with surgical intervention and the Alice forceps closure and the clamping and we found that prophylactic embolization of feeding vessels of such patients really avoid too much bleeding post-operative. And so very important to make angiography for such a patient and to inform and keep him stand by during the intervention, during the operation, to just proceed for injecting for embolectomy of the feeding vessels to avoid too much bleeding. This I want to stress in such situations because we find sometimes many patients with placenta previa or normal position of placenta, and the patient suffering from severe bleeding and going up to hysterectomy after that to control the bleeding. And so just prophylactic examination and prophylactic intrauterine balloon or prophylactic uterine or internal iliac embolization and temporary embolizations may guard against hysterectomy and against severe postpartum hemorrhage. Intrauterine balloon, just keeping it for 12 hours or less than 12 hours may be sufficient for controlling bleeding. And even if you can apply cervical circulage for postpartum controlling and to make the tamponade more efficient for controlling the bleeding, and we can use Foley balloon tamponade or other catheters could be used for this maneuver. Sometimes we use both intrauterine balloon tamponade and uterine artery embolizations, and we find no difference between the two. And even if we use one, it is efficient or sufficient in most situations. Bakary balloon also could be used for conservative management of postpartum hemorrhage. And so angiographic embolization is very important, and just need conscious sedations and injecting contrast through the femoral artery and planning your vessels, pelvic vessels, and select the vessels which will give you the bleeding tendency. And even after injection, you can give another contrast and be sure there is no oozing from this from the uterus. Another case, 38 years old multigravida woman diagnosed with amniotic fluid embolism and appeared with hypotension, pulmonary edema, and cyanosis during delivery. This meaning she developed the cardiovascular collapse, pulmonary edema, and cyanosis, and so entered in RDS, respiratory failure. When the patient bleeds seriously and platelet and the coagulation factor progressive decreased, and these parameters is, I think, most of you agree me, and you saw many cases in such situations with all the coagulation parameters are disturbed, platelet going down, thrombocytopenic, PT is the extrinsic coagulation system is affected, BTT, the intrinsic coagulation system is affected, and creatinine going up, and white blood cells from the stress also is high, hemoglobin is low from hemolysis, and so on. These typical cases of DIC and the clinical scenario, and you see more increasing BTT, decrease the platelet, fibrinogen decrease, may be high in the first few hours due to acute phase protein formations. Thrombin time also, which is a common pathway of coagulation, is increased. FDP and the D-dimer is increased. Of course, the D-dimer is more specific for fibrin. And so there is DIC, disseminated intravascular coagulation, this meaning disseminated all over the body. There are too much coagulation, too much consumption of coagulation factors, too much fibrinolysis. And so the FDP and the D-dimers are high, and also the coagulation factors are consumed. And so all the factors are affected and all the parameters are mostly abnormal. And I think this is differentiate, we can differentiate it from TTB. In TTB, you can see the PT and the BTT normal because the coagulation factor are normal, not affected. The affection in TTB is due to Adams 13 deficiency, and so von Willebrand factor overactivated, and so there is a shower of thrombi which formed only of platelets. Here, emboli formed of platelet and RBCs also, in contrast to TTB, which the emboli formed of platelets only most. Heparin we can give heparin in such a situation, in such situations of bleeding and so on. As you know, DIC is classified to acute and chronic state. But we can give heparin in chronic cases to control the bleeding, to control the consumption of coagulation factor, and to control the thrombus formation. But in acute situation in which there is too much bleeding, we can give replacement therapy like fresh frozen cryoprecipitate because it includes factor 8 and platelets and other factors. Also, we can give prothrombin concentrate complex and so on. But exception here, in cases of DIC developed during amniotic fluid embolism or intrauterine fetal death and so on, we can give heparin. And don't forget, the amniotic fluid embolism causing many problems. In addition to DIC, it can cause severe sepsis because it carries some bacteria and so on. Also, it is an antigenic, and so it may cause anaphylactic reaction and anaphylactic shock. So early recognition and the prompt initiation of proper management is essential in such situations for the patient with amniotic fluid embolism. And we take care of microbial invasion in such situations, and they need, of course, management with antibiotics because they suffer from sepsis. It leads, amniotic fluid embolism leads to RDS and DIC, seizures, encephalopathy, and so on. And as I told, heparin could be given in chronic cases, in acute cases, and in such a situation of obstetric causes of amniotic fluid DIC. It is a defibrillation syndrome, as we know, and we informed or summarized the role of heparin in such situations. In etiology of DIC, of course, is the exposure to tissue factors, trauma, severe sepsis, especially sepsis with meningococci, E. coli, all these can cause DIC, which causes severe bleeding from every part of the body, from all the orifices of the body, even the venous puncture and so on. And so the early stage or acute stages of DIC need replacement therapy to correct the consumption coagulopathy which is happening. All these severe shock also may cause cancer, particularly mucin secreting cancer as adenocarcinoma of the pancreas, adenocarcinoma of the prostate, acute promyelocytic leukemia, tumor cell express and expose or release tissue factor. All these can predispose to the DIC. There is common causes as severe tissue damage and trauma, complications of prostatic surgery, enzymes sometimes inserted as snake venom toxins, profound intravascular hemolysis, aortic aneurysm or cavernous hemangioma. We can see the cases of DIC subsequently. Bleeding, we'll find bleeding into organs along with microvascular thrombosis, which cause, of course, dysfunction of this organ. And so it is a multi-organ dysfunction syndrome, and because it's defect of perfusion to the tissue and so affect many organs. Slowly evolving DIC produces mild thrombocytopenia, normal or minimally prolonged BT and BTT, normal or moderate use of fibrinogen level, increased plasma D-dimer level. Of course, the rapid one or severe rapid will give you a high parameters, BT, BTT will be affected, also the thrombin time, D-dimer, all will be high or abnormal. Rapidly evolving DIC result in more severe thrombocytopenia, more prolonged BT, BTT, less fibrinogen, high plasma D-dimer. Factor 8 level is elevated in hepatic necrosis. And so we have to differentiate between DIC. In some situations, we may face difficulty in differentiation between hepatic failure and the DIC. In hepatic failure, factor 8 is elevated. In contrast, in DIC, the factor 8 is dropped. Treatment, of course, as we told, in acute cases, we have to support with replacement therapy. In chronic, we can give heparin. You can give platelet concentrate, cryoprecipitate, fresh frozen, prothrombin, PCC, prothrombin complex concentrate, volume replacement, of course, very important. Fresh frozen to replace the antithrombin protein C and S and Z, which is a natural anticoagulant. All these are important. Heparin, or as I told, in chronic cases, or exception in cases induced by obstetric problem as placenta abruption or severe intrauterine fetal death or amniotic fluid embolism. Another case, 29 years old woman, 33 weeks pregnant with a respiratory rate of 55 per minute. Her pregnancy has been complicated by persistent gestational nausea and of course, and vomiting and so on. What is the likely diagnosis? Of course, you know, most of us know this problem, which is hyperemesis gravidarum, which occur mostly in the first trimester. And these lab investigations, as we see here, the patient is, if you see, the bicarb is low, 9, and there is an anion gap high, and so the platelets is normal, white cells may be high from stress, hemoglobin 12.3. Albumin is low and phosphate is normal, magnesium also. And we see here glucose may be normal, the lower limit. Liver enzymes not so high, just AST. And we see the pH, the patient is highly acidotic and anion gap is high. Lactate is low, and so this patient may suffering from some sort of acidotic cause, which is, I think, from starvation and so on, suffering from ketosis. And these patients suffering from hyperemesis gravidarum and admitted to ICU, and after correction and the starting of TPN, the intensivist is hurry in his feeding replacement, and so the phosphate starts to go down, as you see, phosphate 0.36 millimole per liter, and this is the main problem actually in management of such situations in general. Any patient coming to you in ICU suffering from severe malnutrition, especially for a long time, don't start feeding so rapidly. Start feeding slowly, even TPN and enteronutrition. Even enteronutrition, you have to start slowly. Otherwise, you will face with the refeeding syndrome as here, potassium is low, phosphate is low, and this patient is liable for severe arrhythmia and hypophosphatemia, which may predispose to rhabdomyolysis and may lead to cardiomyopathy and severe arrhythmia up to arrest. We saw cases of severe arrhythmia from hypophosphatemia, from refeeding syndrome. And so this case declared the problem of feeding rapidly or starting feeding rapidly in malnourished patients. Start slowly, please, to avoid the problem. This case presentation also represents the liver here is low attenuations under CT after delivery, and this patient presents this typical case of liver infarction subsequent to preeclampsia and HELP syndrome. Thanks for you.
Thank you very much indeed, Prof Elansary, for this really very nice, interesting lecture. I think we discussed actually almost all the obstetric emergencies that we can come across. So we talked about HELP syndrome, we talked about obstetric hemorrhage, amniotic fluid embolism, DIC, and starvation ketosis as well. I see a couple of questions here from Noha Abdul Wahab among the audience. She's asking specifically about DIC. So her question is about what about factor 7 in DIC, in over 7 use in DIC? What's your take or what's your opinion on that, Prof Elansary?
Really, personally, I'm not using it in such situations, and and even in other situations, you must be careful in using factor 7, because I saw many cases developed even MI following its injection. So take it. These are highly pro-coagulant factor, and so don't be hurry in using factor 7. May have a rule, but really I am not using it in such situations.
Of course, I really second that, and whenever
or exactly, I have no experience with it in such situations.
Yeah. I think, Prof, I'm sorry, it's in general. Whenever we run like severe bleeding past the hematologist and ask about Nova 7, they warn us that if it's limb or life, yes, potentially you can use it, but it's a highly prothrombotic. So I totally second what you've said. So we have to be careful. Plus, it's very expensive as well. Her next question is about heparin use in DIC, and she's saying heparin given as single dose. I don't totally understand the question, but
we can give heparin according to the clinical situations. Really, in such situations, you can titrate the doses, and we use low doses and frequent doses every 8 hours or 12 hours.
Right. Another colleague, Yasser Ali, is asking, please recommend on refeeding syndrome. Questions are coming now, actually. I kept
which as I said, always in malnourished patients, or such in our case situations as hyperemesis gravidarum, this patient malnourished since a long time. Don't be hurry in correcting the feeding state of such patients. Otherwise, even by resuming the enteral nutrition, you have to start gradually. As when we are fasting, even we are fasting in Ramadan for 12 hours, so on, we can start feeding slowly, not so high. Otherwise, in such situations, the patient will develop what we call refeeding syndrome, severe disturbance in the electrolyte balance in your patient, hypophosphatemia, hypokalemia, hypomagnesemia, and all these predispose to many complications, most important with arrhythmia and VF and the rest.
Yeah, one last question, Prof. Ansari, sorry, because of the time. I know if we open questions, we'll never stop. So it's a very interesting question about TXA, about tranexamic acid. So Ali Saad is asking, how much and how long can we use tranexamic acid for coagulopathy and DIC? I know there is very strong evidence for obstetric.
Of course, if you find your patient exhibiting more fibrinolysis and through the high D dimer, you can give epsilon aminocaproic acid or tranexamic acid. You can give 4 grams from epsilon aminocaproic acid, and you can repeat after that if the patient exhibiting some response.
Right.
Mahmoud have more experience, he can tell us. Dr. Mahmoud, our genius.
You're the expert, Prof. Ansari.
We work with him many years in ICU, really highly intelligent, highly intelligent.
Thank you very much. It's actually.
I think we have Prof. Nasir Rifai here. She's expert in obstetric anesthesia, and she can comment on that point, please.
I have a last comment about amniotic fluid embolism. I've read few studies, it was case report about using ECMO as a last resort for amniotic fluid embolism, and it gave very good results. Do anyone has experience with using ECMO in such cases?
Really, we use ECMO in other situations, not in amniotic fluid embolism, and using it in about 4 cases before. And maybe I am unlucky in the prognosis of such patients. Most of our patients, actually, truly, they are suffering from intracerebral hemorrhage and many complications. And as you know, we need too much anticoagulant in such situations to avoid these thrombotic complications. But in other centers, they can gain some success with ECMO. But really, till now, it needs more. May our experience is still not so advanced in such situations.
I have a comment, very quick comment on that, Prof. Ansari. I think in the context of amniotic fluid embolism, most probably things, if they are meant to settle, they will settle without the need for ECMO. And ECMO is like a very expensive resource, scarce resource as well. And you need to do many cases in order to build a learning curve, in order to have outcome. Otherwise, it will be disastrous, really. And in the context of obstetrics, I don't think it's really very widely used. But I don't have experience in that. I'm not cardiac anesthetist.
Just few studies. I've just read few studies in the last 2 years. It's only case record, so it's not commonly used.
All right, Dr. Nasreen, yeah. I have one final question, Prof. Ansari, before closing, and your take on that. the use of thromboelastography or ROTEM in obstetric units in order to guide the topping up of blood products in the context of coagulopathy. We find, and Prof. Fahmy Saad Latif might be able to comment on that later. You know, you have big obstetric units and they go without having a TEG or ROTEM device, which is a very valuable piece of kit for point of care testing for coagulopathy in any obstetric unit. What's your comment on that, please?
Of course, thromboelastography or ROTEM is very mandatory now in any theater which face a high incidence of bleeding problems in the theater, especially any patient with suspected high incidence of coagulopathy or bleeding problems. Better to use thromboelastography because it will mention to you at what time you have to use the different ingredients of blood transfusion. What is the initiation time? What is the amplitude of the clot? What is the strength of the clot? It gives you more information and so more valuable in selecting the ideal item or ideal ingredient of your blood constituent. Don't install it is sparing for your blood transfusion, and also it avoids massive transfusions, which sometimes we use roughly and without clinical basis, without scientific basis, which may lead to pulmonary edema, RDS, trailing, and many complications of blood transfusion. So it must be, every theater now must be equipped like ECG monitor, like ABG, must be equipped with ROTEM or thromboelastography machine.
Prof Ansary, I'd like to repeat my gratitude and thankfulness to your very, very interesting lecture. Sorry, time actually is upon us. I'm aware about time, and there are other stars waiting actually to lecture tonight. So I'd like to thank you very much. And we will be waiting all the time for all your interesting lectures. I'd like to ask Dr. Mahdi, thank you very much. Really appreciate your time and lecture tonight. Dr. Mahdi, who's going to go next? Is it Prof. Fahmy Saad or Prof. Amr Abdel Fattah, please?
I think Prof. Fahmy Saad is waiting.
Right.
Now.
Brilliant. Okay.
Yeah.
So I think I'm really privileged tonight to have the chance to introduce my esteemed professors, those who I grew up learning from their expertise.